when I started being involved in osteoporosis, and I picked 72, but it actually was a little bit before that because I did a PhD and we started seeing people that came in with osteoporosis, I should say women, because we didn't realise it occurred in men, and we had absolutely no treatment that worked. We had no knowledge of anything that made a difference. None. So, you know, if I was talking about what it might have looked like back then, I would have said, well, we know that fracture risk goes up in women as they get older. That would have been the length and breadth of what we could have said with any knowledge. Okay? Then things changed a bit. We actually got, and I've said 2017, but this occurred well before that, we got ways of measuring bone density. We realised that we could measure this in a way that previously you'd look at X-rays, and Marcus Seibel said, you know, if you look at this X-ray and know how to do it, you can say it looks a bit thin, it looked a bit osteoporotic, but you can only tell that on X-rays when you've lost about 50 or 60% of the amount of bone you should have. So it's very little, very late. But we then had a measurement, a tool that you could measure bone density. Initially it was in the forearm and then in the spine and hip, and many of you may have had those measurements. And we also realised through the work that Jackie Center did, you know, in our Dubbo cohort, that fracture risk went up both in men and women, or say women and men. Now I keep stressing this because I think at the moment we keep saying, oh, this is just a condition of women, so little old women. That's not true either, so it really doesn't matter. I don't believe that, but I think that's an approach. Whereas when we realise that it occurs in relatively young people, and I'll come back to that in a second, and it occurs in both men and women, maybe we can get this off the back burner and put it front and centre where it should be. You know, I would point out, although I'm not showing you the data, that the peak incidence of fragility fractures, osteoporotic fractures in the community is around about my age. So I don't consider that terribly old. Others of you may. But we went, and we understood a little bit about it. We thought that nutrition and lifestyle, calcium, protein, exercise, sunlight exposure, all of these things are important as part of our baseline for health. But not long after that, we had studies that showed that in women, now this was in women, that hormone replacement therapy, and we went through a stage where we were only allowed to call it hormone therapy. We'd be shot if we called it hormone replacement, but now we're allowed to call it hormone replacement again. Politics is interesting. We had studies that showed that this was really effective. It preserved the bone, and the bone that women were otherwise losing was actually preserved. And of course, men who have low testosterone for whatever reason also lose bone as rapidly as women do. Now, I'm not going to try and get you to understand a whole lot about bone, and Paul Baldock may, and if he does, he'll do a much better job than I do. But essentially, all over your bone, you've got a bit of bone sitting there like that, and normally it's sort of intact, and then a cell comes in called the osteoclast, which is a cell that removes bone. So it digs out, usually it digs out damaged bone. It's part of an ongoing maintenance program. So our bones are changing all the time. In everyone in this audience, your bones now are a little bit different than when you got up this morning. Okay? And it only takes about 7 years for half of your entire skeleton to be replaced. Okay, it's going on all the time. It's a constant maintenance program. It's even more active than what goes around this hospital and this institute. But the bone is removed and then it's replaced. And these are the osteoblastic cells. The osteoclasts break it down. The osteoblasts fill it up. And there's a whole lot of other things in the marrow that these talk to each other. There's fascinating communications that are going on all the time. Our cells are talking to each other so they know what to do. I'm trying to. Mary, can you make me a bit louder, please? Thank you. So this is happening all the time. Now, most of what we have that are treatments for the bone, which now exist, and this, as I say, this is now, looks more complex, but it's actually straightforward. We have drugs like SERMs, like raloxifene, tibolone, or Livial. We have the bisphosphonates that were fabulously done about just on 20 years ago is when they really burst onto the screen with high-quality randomised controlled trials, which is the highest level of evidence you can get in medicine, showing they reduced the risk of fractures. Sadly, we still don't have anything that means that you'll never fracture, but we have things that reduce the risk and arguably make the fractures not as bad as the ones you might have otherwise had. This group of drugs, the bisphosphonates, some of you would have heard it as Fosamax or Actonol or Aclasta, and now another one which works in a different way, but on the same pathway, called denosumab or Prolia. They're the injections. All of these now have been validated as being absolutely outstanding and excellent treatments. Parathyroid hormone, teriparatide Forteo, some of you may have had. This is another alternative. And as always, when I say this, every one of these treatments that have been validated on the basis of people already getting good nutrition, good protein, good calcium, adequate vitamin D intake, and so forth. So that's the basis of it. Now, this was from, this particular diagram, I'll explain to you in a moment, was from this study that was done just on 20 years ago now that really changed the whole world in osteoporosis. It was a large study, cost a huge amount of money to do. I think it was about $500 million US. Carried out around the world. And what it showed, that with this particular treatment, you reduced the risk of spine fractures, either ones that you could see by an X-ray or ones where somebody actually said, I've got back pain, and you could show they've got an X-ray, by about 50%. And a whole lot of other fractures, including hip fractures, wrist fractures, and then a whole range of other fractures by somewhere between 30 and 50%. This one that sticks out, these are the multiple spine fractures. These are the fractures that change somebody from looking like this to looking like this. That should not happen anymore. We can't stop all fractures, but nobody should end up like that now. So we have these treatments that are available. Now this is with Fosamax. I could show you pretty much exactly the same slide with Actonol or Residronate, with zodronic acid or Aclasta, with Prolia, denosumab. All of them show very, very, very similar patterns. That's what they look like. They're very effective. They all do very similar things. There are advantages and disadvantages for each of them. But they're very well tolerated, they're very effective, and frankly your risk of getting a serious side effect with any of these is about the same as your risk of being killed on your way to, in a car accident on your way to this symposium. Well, over a period of time anyway. So if we think about it, we've got these cells that are removing bone, we've got cells that are replacing bone. Most of the treatments that we currently have work here. They try and stop the bone removal. What I'm going to talk to you about now, just for a little time, are the treatments that can actually build new bone. Because for most people, by the time the diagnosis is made, people have already lost a lot of bone, maybe 30 or 40% of the bone they may have had when they started. And we can stop further loss, usually get some improvement and then stop further loss. What we're interested in is what about treatments that might improve the bone. So there is one that Paul Baldock will probably touch on again, which came from animal studies, understanding what was happening. This was an antibody that is given as an injection, and it interferes with the communication of these cells in bone. So these cells that remove the bone do so on the instructions of other cells. You can think about them as a whole lot of council workers sitting around waiting for instructions, you know? and they're not doing much, but then they get a message, dig. At the same time, and they're the things that we try and stop, at the same time, there are other things which tell the cells in the bone, we need more bone. And the body has a series of checks and balances, and one of them is this particular protein here, sclerostin, which says, no, don't make any more bone at the moment. By making an antibody that blocks that, we get more bone formed. It's a truly anabolic effect. I'll come back to that in a moment. But what's interesting, this was a comparison of people who were treated for a year with this new particular antibody versus standard treatment, which is just calcium and vitamin D. Okay, just making sure everything was okay, that's all they got. And what we saw is if we looked at, and I can show you in other places as well, it looked at new spine fractures, there were fewer in the people who were given this new treatment. Now, if you may remember, and this is at 12 months or at 2 years, you may remember I said that almost every one of the drugs we had pretty much halved the risk of fractures, of spine fractures. Do you recollect me saying that just a little bit before? Here, there's about 75% fewer fractures. So 3/4 of the fractures were prevented. Now, this is a comparison against the placebo, the one that's just the pretend injection. And we always have to do that in these studies so people don't say, oh, I feel much better because I know I've got the special treatment which is pink and looks good and whatever. Yeah. They subsequently, this same group, or the same, it's supported by the company that's developed it, and several of the same investigators went on and did a comparison. What happens if you compare this drug to the very best treatment, the level of treatment we have? And I said to you, all of these drugs like alendronate or Fosamax, all of these ones are very similar. This is the first, what we call head-to-head study that had ever been done in the world of these drugs, types of drugs. And what it showed, that if you looked at the people who were given this injection, this antibody, versus the people who were given Fosamax, either at 12 months or 24 months, there were substantially fewer fractures. In other words, we were doing better than what is otherwise the best we'd ever done. And again, if you looked at this, even in 12 months, there were 25% fewer fractures. At 2 years, there were nearly 50% fewer fractures. Fewer fractures than otherwise we were getting the best treatment we had. The other one that's interesting is this particular drug, again, was compared, and I'll try and explain it to you in a moment, against the only other anabolic agent we currently have, which is Forteo. And this is not looking at fractures, but it's looking at what happens to bone. And in particular, what's important about this, and this has just been studied, but just been published, this was after people had already had years of treatment with these drugs designed to reduce the bone removal. So even after that. And what you can see there is these are the people that were given teriparatide, not much of a response in that first year. We're not surprised about that, certainly not in the hip, some in the spine, but in the ones that were given this antibody, they actually did better in terms of bone density. And we think that would mean they would still be better in terms of getting a better result than what we would otherwise think is the only other anabolic agent we have, which is Forteo, this is very early days, but it's very exciting. So what we currently have at the moment, that we have drugs that are very good at reducing excessive bone removal. They are excellent at it. We are starting to get drugs that are driving more active bone formation. We really need those because we often miss the point and people are not seen until relatively late, and that's where I'm stopping. Thank you.